Good evening, everyone, ladies and gents from all over the country. So glad you could join us tonight. I'm based in Port Elizabeth and I cover the Eastern Cape, and I'd like to just introduce my colleagues. Sajidah Khan, she's with me in the Eastern Cape, and then we've got our KZN colleagues, Taryn Hayes-Hill, accompanied by Jason Garderman, and I believe Verona Naidu is also online. So you are supported by a bevy of Servier representatives online, and we just thank you for being interested and keen to attend the meeting, which is fully CPD accredited by ECIPA. I'll hand over back to you, Doctor.
Thanks very much. From ECIPA Healthcare in the Eastern Cape, I'll now go ahead and introduce Dr. Khan. I'll endeavor to summarize extensive abbreviated CV. Dr. Khan is a cardiologist and she qualified with MBCHP at the University of Natal, and she has a PhD in molecular cardiology from UKZN, FCP, SA, and Fellow of the American College of Cardiology, Fellow of the European Society of Cardiology. She was the previous director of the Cardiac Catheterization Theatres and Cardiac ICU at Nkosi Albert Luthuli Central Hospital in UKZN, and she is a member of 11 international and national committees, and also has been involved in 9 international interventions, and she has been the only South African to have been asked to lead the great debate and opening session of the EuroPCR, which is the most prestigious and largest interventional cardiology meeting in the world. She is also on the advisory board of 7 companies, pharmaceutical companies. She is the journal reviewer of the European Heart Journal, the Cardiovascular Journal of Africa, and editor of South African Heart Association newsletter. She has been involved in 22 recent peer-reviewed publications and 7 recent research projects. I'm not going to read them for now to summarize. And there are several ongoing studies on molecular mechanisms of atherosclerosis and type 2 diabetes with investigation of novel signaling pathways, sirtuins, and microRNA. So with that, a warm welcome to Dr. Khan. Over to you, Dr. Khan. Thank you.
Thank you, Jeff, for that rather pompous, I don't know who you're talking about, it doesn't sound like me, and I don't know where somebody fished out a CV like that. But thank you anyway, and thank you to Servier for asking me to address you on hypertension. It's a bit intimidating. Hypertension is a very old topic, and I'm sure you all know as much as I'm going to tell you, if not more, on the condition. I'm just trying to go on to slide share. Give me a moment. Can you see that clearly?
Yes.
Jeff, is that all right?
Perfectly clear, Dr. Khan. Thank you.
Okay, so we'll get started. Jason from KZN chose the topic of calling it hypertension under pressure, and it's understandable why he's saying so. During the current era, hypertension has been associated with higher rates of infectivity and poorer outcomes. There's a doubt regarding therapy with our best agents, which are the ACEs and the ARBS, as both of these increase the ACE2 molecule, which facilitates entry of the virus into cells. Additional problems are the limited contact with medical personnel, as well as access to medication. And importantly, greater reliance on patient self-monitoring. Now, despite the huge public health burden of hypertension. As you all know, 35 to 40% of the world's population suffer from this chronic disease of lifestyle. And in spite of sustained research efforts, there has been slow progress in the global control of hypertension. In middle and low income countries, at best between 23 and 35%, and even in high income countries, control at best occurs in 42% of treated hypertensive patients. And there is no new drug development on the horizon. There are over 7,000 studies on hypertension to date, and all we can do is repurpose old therapies. This is a buzz catchphrase at the moment. And in this era of reliance on biotechnology, there are more than 11 technologies that look at improving or curing hypertension. And to date, the best that we have is renal denervation. But what we've learned from initial experience with this type of biotechnology is that they're not really superior to medication. In head-to-head trials, what has been the foremost conclusion is that under trial conditions, when patients are scrutinized and if they take medication, there is no superiority of any available technologies to date that can beat medical therapy. So adherence is a huge issue in terms of control of blood pressure. So the agenda briefly I'm going to speak about is, when do we treat hypertension? What are the best drugs that we have at our disposal? And the impact of comorbidities that influence our choice of medication. The eternal challenges are adherence to therapy, tolerability, and affordability that determine our choices. Regards when to treat, we know that blood pressure fluctuates from moment to moment. So it's very important that we measure in a standardized manner. And in the current era where reliance on self-monitoring is important, it is vital that we inform patients on correct techniques. So I'll briefly just reinforce what is correct technique for the measurement of blood pressure. Before one embarks on measuring blood pressure, for 30 minutes beforehand, do not exercise, do not smoke, do not have too much of caffeinated drinks. You should have emptied your bladder, and you need to remain seated and relaxed for at least 15 minutes in a quiet room with a comfortable temperature, as too high a temperature lowers blood pressure and a very cold environment increases blood pressure. Importantly, neither the patient nor staff should actually be talking before, during, and between measurements. It's always conducive when one's measuring blood pressure because the patient has intimate access to the doctor, and often doctors use the opportunity to take a history. But this is not the time that it should be done. Patients needs to be seated and the legs need to be uncrossed with the mid-arm and the cuff at the same level as the heart. Importantly, the cuff should not be placed over clothing. And you know the age-old teachings that smaller cuffs overestimate and larger cuffs underestimate blood pressure. Importantly, the inflatable bladder of the cuff must cover at least 3/4 of the circumference of the arm. One needs to take at least 3 measurements at 1 to 2 minute intervals. The first blood pressure recording must be discarded, and an average of the last 2 measurements should be used to estimate blood pressure. If the initial reading is less than 130/85, no further measurement is required. It's important that at the first visit, especially if you're going to inform patients to take blood pressures at home, that you measure the blood pressure on both arms. And if there's a discrepancy of more than 10 millimeters of mercury in one arm over the other, use the arm with the higher blood pressure. Obviously, if the discrepancy is more than 20 millimeters of mercury, you will investigate for a secondary cause such as coarctation. But remember, if there's a large discrepancy of about 10 millimeters or more, consistently use the arm with the higher blood pressure. In order to diagnose hypertension, you need 3 office visits documenting a blood pressure of greater than 140/90. Just to reinforce, feet flat on the floor, the blood pressure monitor and the cuff at the similar level as the heart. So what are our targets? In patients below the age of 65 years, our target is less than 130/80, but not too low. We don't want readings that reach below 120/70 if we can help it. So in the elderly, as well as diabetics who are newly initiated on blood pressure therapy, it's important to take not only supine, but also standing blood pressures so that there is no orthostatic hypotension. In older patients, we aim for levels around 140/90. But in the advanced elderly, it's important to individualize therapy because one of the commoner reasons for admissions in elderly individuals is falls, and blood pressure medication exaggerate orthostatic hypertension and increase of falls and injury as a consequence in the advanced elderly patients. If there is doubt in terms of the diagnosis, we are quite reliant on 24-hour blood pressure assessment. And here, the equivalent of a cutoff in terms of diagnosing blood pressure is a level of 130/80. You need to inform patients that when we diagnose hypertension and initiate therapy, we do not expect immediate control of blood pressure. We aim for ideal blood pressure control within a period of 3 months because we start low and go slow in order to encourage tolerability and patients to achieve steady state of a drug. So when do we treat? Okay, we need to understand that the most important purpose of treating hypertension is to minimize the risk of future cardiovascular events. A cardiovascular morbidity, mortality is the commonest cause of death worldwide. And hypertension, although it's the commonest chronic condition of lifestyle, it is inadvertently occurring in combination of multiple other risk factors. How do we establish risk in an individual patient? There are multiple risk scores. This can be easily accessible. The Framingham risk score that we use in South Africa has been adapted from the international score. There are other scores that the European Society of Cardiology, the American Society of Hypertension use. But the simple score just utilizes age, the lipid profile, looking at total and HDL cholesterol, blood pressure, whether treated or untreated, as well as smoking. We do not include diabetes in the risk score because immediately the presence of diabetes puts you in a high risk category in terms of cardiovascular morbidity and mortality. In the absence of risk scores, a reliable estimate in daily practice looks at certain parameters. BMI, and even if BMI within normal range of 25, in certain population groups, abdominal obesity takes precedence, and this is especially applicable in South Asians, okay? Abdominal circumference of more than 90 in males and more than 80 in females predisposes to metabolic syndrome, which we know approximately doubles the risk of cardiovascular disease. In Europeans and members from the African population. Cutoffs are slightly higher, 94 centimeters in males. But if you look at the US criteria, I suppose because of the very large burden of obesity in that community, the cutoffs are higher. But what we adhere to is, as I've indicated on the left-hand side. Importantly, when we look at BMI in certain sectors of our population, and this is especially applicable to whom we call South Asians, the cutoff BMI is 23 and not 25 in terms of assessing cardiovascular risk. Smoking, diabetes, high LDL cholesterol, as well as a heart rate above 80 beats per minute, because it's a crude assessment of cardiovascular reserve. And the higher your heart rate, the lesser your cardiovascular reserve and your fitness levels. And this is a subtle marker of higher risk. Obviously, age, increasing age adds greater risk. Male gender above female gender, early onset menopause, a family history of premature cardiovascular disease or hypertension, as well as psychosocial factors such as depression and socioeconomic factors, where lower socioeconomic communities are more prone, not only with higher prevalence of hypertension, but also poorer control. In addition to what we've spoken about in terms of assessing daily risk, subjects who are considered at very high risk of cardiovascular events, and in these subjects, we don't look at the risk score in determining low and intermediate risk. Those who have established atherosclerotic disease, and this includes coronary, cerebrovascular, as well as peripheral arterial disease. The presence of diabetes clearly puts you at a higher risk, as does familial hypercholesterolemia or chronic kidney disease with the GFR less than 60 moles per minute. What do we mean by established disease? In terms of the heart, it's not only coronary artery disease, it's heart failure, atrial fibrillation, or LVH on an ECG. Atrial fibrillation and heart failure and diastolic dysfunction all occur in a basket linked to obesity, abdominal obesity, and especially obstructive sleep apnea. In the original slide, I did mention as part of obesity assessment, what may assist you in addition to a history of snoring and daytime somnolence is measuring neck circumference. And if you have a neck circumference greater than 40 centimeters, that is a pointer towards obstructive sleep apnea and a higher propensity of these conditions. Established disease in the brain is obviously stroke and TIAs, as well as cognitive decline and memory loss due to microinfarcts, ischemic microinfarcts as a consequence of risk factors. Kidney disease we've spoken about, and peripheral vascular disease, which includes aortic aneurysms and aortic dissection. Importantly, we need to be aware before we immediately alter drugs or add new medication, is to be aware of drugs and other supplements that exacerbate or induce hypertension. Commonly used are non-steroidals. Obese population has osteoarthritis in weight-bearing joints. The aging population due to degenerative spinal disease or osteoarthritis, a high usage of non-steroidals. And the non-selective non-steroidals are clearly shown to increase blood pressure. But although aspirin is a non-steroidal, hard evidence is that it does not per se increase blood pressure. Non-steroidals also antagonize the effects of RAS inhibitors and beta blockers in terms of controlling blood pressure. A second class of commonly used agents, antidepressants, Selective noradrenaline and serotonin reuptake inhibitors are known to increase blood pressure, as well as the tricyclic antidepressants, which increase blood pressure at an odds ratio of greater than 3. There has been no evidence to indicate that the selective serotonin reuptake inhibitors have an effect on blood pressure. Oral contraceptive pill, not only in younger women, but also as part of hormone replacement therapy in middle-aged or elderly females. Estrogen in a dose of greater than 50 micrograms or even progesterone contribute to increased blood pressure. Commonly used analgesics, not only the non-steroidals, but clearly paracetamol. In textbooks, you read of acetaminophen. This is paracetamol or Panado's name in the United States. With daily use of Panado, there's an increased relative risk of greater than 1.3 in terms of inducing blood pressure or contributing to poorer blood pressure control. A whole host of other medications, steroids, Betmega, commonly used in men with benign prostatic hypertrophy, increases blood pressure. And in fact, Betmega is contraindicated in patients with systolic blood pressures above 180. There are good trials showing that it really pushes these patients into severe refractory hypertension. Antiretroviral therapies, especially protease inhibitors, increase blood pressure. Common symptoms used in cough mixtures or nasal adjustments, and pain therapy, as well as drugs used in transplant patients and anti-cancer agents increase blood pressure. Alcohol intake, the use of licorice, commonly used over the counter, St. John's wort used for depression, and euhimbine, which is used for erectile dysfunction or induced hypertension. So we have drugs.
Colleague, sorry, we seem to have lost Dr. Khan. I'm sure she'll rejoin.
Sorry, can you hear me now?
Welcome back, Dr. Khan. Yeah, you were just breaking up there.
Sorry, the internet connection is not the best. Did you go to the last slide? Which was the last slide that you...
Yeah, you were talking about, this was the last slide, right? You were speaking about, you were on the last line.
Okay, all right, okay. So when do we initiate treatment? We use a risk score to establish your risk category. If you're a low-risk individual and found to have a blood pressure above 140/90 on at least 3 occasions, you must try lifestyle intervention for a minimum of 6 months. And beyond 6 months, then you may consider initiating treatment. But if you're a high-risk individual, as we've said, diabetic or cardiovascular disease, or chronic kidney disease, then you start drug treatment immediately. Clearly, if you have grade 2 hypertension, which is a blood pressure above 160/100, or grade 3, which is greater than 180/110, immediate drug therapy should be initiated. So how do we decide which drug to start with? We need to emphasize what is the ideal antihypertensive. The most important is those therapies that are evidence-based in terms of reducing both mortality and morbidity. A once-daily regimen is favored. Drugs need to be affordable and well tolerated. The first choice therapy could either be an ACE inhibitor, which is the favored agent of, or if you are unable to tolerate an ACE inhibitor, calcium channel blockers may be considered first line, as well as thiazide-like diuretics. The greatest evidence in terms of mortality and morbidity is with the RAS inhibitors, especially the ACE inhibitor. This table looks at mortality reductions in meta-analyses, comparing the two agents considered best and most effective in terms of morbidity and mortality. Looking at meta-analyses of hypertension studies, ACE inhibitors on the left-hand side, which favors mortality reduction, is found to be superior to ARBS. Similarly, in diabetic patients, the ACEs trump the ARBS. In coronary artery disease, as well as high-risk individuals with multiple risk factors, studies to date show that ACE inhibitors overall have an approximate 10% greater advantage over ARBS in terms of mortality reduction. In addition to mortality and morbidity, we look at single agents used as a once daily regimen. There has been much written about taking antihypertensive therapy at night. The most popular study that really brought this to the fore in a 2019 publication. If you're not aware, both the author of that paper as well as the entire study is under investigation. So what we do know from multiple trials is that there are only 4 antihypertensive agents that have 24-hour efficacy. Amongst the ACEs, it's perindopril. Amongst the ARBS, it's telmisartan. Amongst the calcium channel blockers, it's amlodipine. And amongst diuretics, it is indapamide. These 4 agents give you 24-hour control. So the issue of whether you take it at night or in the morning doesn't really factor. I'd like to draw to your attention, for example, if you take a diuretic such as hydrochlorothiazide, its duration of action is only over 33% of a 24-hour period. If you look at other ACE inhibitors or ARBs, at best, you get between 50 and 80% coverage throughout the day. In terms of diuretics, and I like to emphasize this, we always favor a drug such as indapamide.
Apologies, colleagues. I think Dr. Khan is having a problem with the internet again. She's frozen. We'll get one of the reps to rejoin now. Thank you for your patience and understanding.
In addition to metabolic neutrality, there's superior profiles in terms of electrolyte abnormalities, as well as all diuretics may induce gout by increased uric acid levels. And amongst the diuretics, indapamide is the least likely to increase levels of uric acid. When we look at the triple therapy, and the drug that Servier has, triflixim, is a combination of these 3 agents, indapamide, perindopril, and amlodipine. And as I've indicated, these are the only drugs, in addition to telmisartan, that gives you 24-hour coverage. Indapamide, importantly, has a peak effective action within 1 hour, and being a diuretic, It's preferable that this is so you don't end up having to have diuresis at night. Perindoprol peaks at 3 to 6 hours and amlodipine at 6 to 12 hours. So you don't get a precipitous drop in blood pressure at initiation of therapy because of the pharmacokinetics of these three agents. The core algorithm then, when we manage blood pressure, if you're a low-risk individual with grade 1 hypertension, you can use any one of these three agents, but the favorite is the ACE inhibitor. Step 2, if you're uncontrolled with any one of these agents, it's preferred that you use a dual combination, either an ACE or ARB with a calcium channel blocker, or that combination with the diuretic. If you're still uncontrolled with a single dual combination, then we use a triple combination, an ACE and an ARB together with the calcium channel blocker and a diuretic. And the drug that Servier has is triplicum, which combines these three agents. And fourth step is that's when we introduce a second pill, a triple combination. And the drug that's added after the triple combination is spironolactone. In fact, we can't call somebody having refractory or resistant hypertension unless they have mineralocorticoid receptor blocker. Over and above spironolactone and these three agents, other agents that we can add as a fifth line therapy is an alpha blocker or a beta blocker. Now, step 1, when we talk about low dose dual combination, you can use perindoprol or amlodipine or perindoprol and indapamide. And low dose is meant by half of each of these agents. When that doesn't control blood pressure, we use a steady state period of at least 2 to 4 weeks. And thereafter, we can go to a full dose dual combination. And if that doesn't give us our desired blood pressure level, you go on to the triple combination, and the triple combination comes in variable doses. Perindoprol as a dose of 5 to 10 milligrams, indapamide as 1.25 to 2.5, and amlodipine as 5 and 10 milligrams. Now, these combinations, not only do they facilitate single pill usage, they also work synergistically and also counter side effects. For example, the ACE cough with perindoprol in combination with amlodipine is shown to have less cough. Amlodipine that induces pedal edema in combination with perindoprol clearly found to have less pedal edema. The hypokalemia with indapamide is counterbalanced with the increased potassium levels with perindoprol. So these three agents, in addition to being single agents, improve tolerability as well as synergistic action. And as I said, resistant hypertension, we use a triple combination with spironolactone and then the alpha or beta blocker thereafter. In specific established cardiovascular disease patients, for example, in patients who have concomitant coronary artery disease, you may use an ACE inhibitor or an ARB, a beta blocker, which is generally fifth-line therapy in a standard patient with hypertension. In a patient with coronary artery disease, it can be initiated at any time because of its chronotropic and inotropic effects. Clearly, a statin need to be initiated in all patients, and the LDL target from the new guidelines is a level below 1.4. And those who have multiple risk factors, we aim for a LDL level of 1. And aspirin clearly has to be used in those with established cardiovascular disease. In patients with heart failure, we need to treat to a target of below 130/80, but not too low. We don't want to take it to levels of less than 120/70. ACEs are favored, beta blockers, not atenolol, but carvedilol and bisoprolol, as well as spironolactone. All these three agents reduce mortality. And the newer agent, which is an angiotensin receptor neprilysin inhibitor called ANI, which is used in heart failure with reduced ejection fraction as an alternative to an ACE inhibitor. In patients with chronic kidney disease, ACEs and ARBs are first line because they reduce albuminuria. But in advanced chronic kidney disease, calcium channel blockers and diuretics are favored because the ACE and ARBs lead to hyperkalemia, and diuretics really can't be used if your GFR is less than 30, and a loop diuretic needs to be used. Often in advanced kidney disease, because of resistant hypertension and hyperkalemia, it precludes use of other agents. And in this instance, agents such as doxazosin, an alpha blocker, become very useful in controlling blood pressure. In those who have had previous strokes, both ACEs and calcium channel blockers are considered preferred first-line drugs. Statins to lower LDL to less than 1.8, and aspirin for ischemic but not hemorrhagic stroke should be used. When you have concomitant diabetes with hypertension, dual therapy is recommended as first line, with an ACE inhibitor as the initial agent. In those who are pre-diabetic, the risk of new onset diabetes is lower with an ACE or an ARB, and a beta blocker diuretic combination should be avoided in prediabetes, as this combination favors the development of full-blown diabetes in those who are pre-diabetic. In terms of diabetes and newer agents, there are two new class of drugs that have really come to the fore: the GLP-1 receptor antagonists that on their own have been shown to reduce blood pressure because of the effect in reducing weight, but more importantly, the SGLT2 inhibitors, trade names Jardiance and Forxiga, which really have altered the playing fields in not only reducing cardiovascular mortality, improving outcomes in heart failure, as well as those with chronic kidney disease. These effects are not only seen in diabetic patients, but also in non-diabetic patients. And the SGLT2s act as diuretic agents in having an effect on blood pressure. And the blood pressure lowering effects of these agents must be taken into consideration when managing hypertension, especially in the elderly, because it may lead to dehydration and precipitous falls in blood pressure. Other issues in hypertension, for example, in those who are taking antiretroviral therapies, you need to be aware that there are interactions between calcium channel blockers and to a lesser extent with beta blockers in those who take ARVs, especially protease inhibitors. So choice of other agents such as the ACEs and the ARBs and diuretics become more favorable in these patients. I was also asked to talk about aspirin in primary prevention because we're looking at patients who have multiple comorbidities, and there has been much controversy in terms of whether aspirin, which is clearly a stalwart drug in secondary prevention, but has been frowned upon in patients for prophylaxis in terms of primary prevention. The data to date suggests that both in low-risk individuals and intermediate-risk individuals. And as I said, we establish risk by looking at risk scores such as the Framingham risk score. Aspirin should not be used in these agents. And what the data says, just to summarize, and I've just looked at the meta-analyses, if you take 1,000 patients starting at the age of 40 and using aspirin for more than 10 years, all that you're able to do is prevent 5 myocardial infarcts and 7 colorectal cancers, meaning that 980 individuals taking aspirin for 10 years will see no benefit, but you will increase the risk of bleeding. So in low-risk individuals, to date, aspirin should not be used in primary prevention. Similarly, what is the data in terms of intermediate risk individuals? By intermediate risk individuals, we mean that those who have a risk of cardiovascular events of 10 to 20% over a 10-year period. In this intermediate risk group, if you use aspirin daily for 10 years, in 1,000 patients starting at the age of 60 years, you will have 17 fewer myocardial infarcts and 13 fewer cases of colorectal cancer over a 20-year follow-up. So the data suggests no aspirin use for primary prevention in low-risk individuals, in intermediate risk individuals, and certainly those above the age of 70 for primary prevention. However, if you're a high-risk individual, meaning your 10-year risk is greater than 20%, and this is typically individuals over than 40 years with multiple cardiovascular risk factors, as well as diabetics, aspirin use can be considered for primary prevention. And the data suggests, although not clear, that majority of these patients should be given aspirin in a dose of 75 to 100 milligrams per day. Lastly, when it comes to adherence, we like to look at reducing polypharmacy and use of single pill combinations. Dosing, again, once daily dosing versus multiple times a day, and affordability. What data suggests, if you look at single pill combinations, and this is a solid line versus 2 pills, looking at the commonly used effective agents, perindopril and amlodipine, adherence is clearly improved with the single pill combination. And not only adherence, this also translates into the hard endpoint of superior mortality benefit in single pill versus 2 pill combinations. And in terms of SARS and ACE and ARBS, there's been much written, and I'll just highlight the recent meta-analysis published in Nature recently. It's clear that using ACE and ARBS in those who are COVID positive neither increases the risk of viral infectivity nor increases the severity of the infection compared to those not using these medications. Instead, ACEs and ARBs in these patients is associated with the trend towards a reduction in the risk of mortality compared to those not using these medications. Just to show you the bar graph, looking at the meta-analyses of all the studies to date in patients with COVID-19, and these studies have a total of just over 2,000 users of ACEs and ARBs as compared to 6,500 not using ACEs and ARBs. In these dedicated studies, the overall effect is a slight favor towards a decreased mortality with these agents. I'll stop there and wait for questions. Thank you.
Thanks very much, Dr. Khan, for a clear, well-paced, comprehensive, and most informative talk on hypertension. And thank you for covering the basics as well and not leaving it out, assuming that we know it all. It's always good to have that covered. So I'll kick off with a few questions and then open it up to the audience. We're noticing that there are patients who are developing hypertension post-COVID. What are your comments on that, and what would be the mechanism? Also, there seems to be a tendency that the blood pressure tends to fluctuate in these cases. Thank you.
The blood pressure fluctuation, we do see that, and this is due to several factors. We don't really know why. Okay, the blood pressure is often associated with arrhythmias, usually a tachyarrhythmia and a bradyarrhythmia. We see low heart rates, we see high heart rates, we see the POTS syndrome. The exact mechanism is unclear, but we will treat in the usual fashion. And in terms of susceptibility, when you look at all your risk factors, hypertension is listed as the one with the most likely incidence of contracting the virus, with the factor of greater than 6% compared to those that are not hypertensive. But this is linked not to hypertension per se, but to an aging population. Hypertension and an elderly, that is the association rather than hypertension per se in terms of increasing susceptibility to SARS-CoV-19. I don't know if that answers your question.
Thank you, Dr. Khan. And just to the attendees, we've posted the link to complete the online register for your CPD points. Please do that. I'll post it again. Dr. Khan, you mentioned that non-steroidal anti-inflammatory drugs increase blood pressure. Does this apply to COX-2 inhibitors as well? Yes,
the only one is celecoxib, but the data on that is variable. Some say no, some say a 3 to 5% increase in blood pressure. So as a rule, limit your use. There is no clear-cut non-steroidal that will afford you. Celecoxib is the only one, and but the data on that is variable. Some studies saying no effect, others saying no. Just like every other non-steroidal, it does contribute.
Thank you, Dr. Khan. And then there are times when patients react to ACE inhibitors, and the allergic reaction with the swelling, angioneuritic edema, and then at the same time, I've had a patient who has that and extreme edema with the amlodipine. Where would you move to from there if you're not able to use those two drugs?
Okay, angioedema, you must know, is especially common in the Black African population. The incidence of angioedema is 3 times higher than other population groups. So you need to be especially wary, and although it's a very effective drug, be mindful of that. They are more susceptible. In terms of the ankle swelling, that is clearly seen with the higher doses of calcium channel blockers. So therefore, when we have combination drugs and the triflixim combination, studies have shown that the higher doses of amlodipine together with indapamide as the diuretic, as well as an ACE inhibitor, lead to a lower incidence of ankle edema compared to monotherapy of 10 milligrams of amlodipine.
So if you're not able,
yeah.
If you're not able to use amlodipine and ACE inhibitor, what would you use next?
We have a choice of either of one of these 3 agents, all right? The ACE or an ARB. I always favor an ACE, and that's a preference because the data, as I said, is superior to an ARB. So obviously, if cough is an issue, you go to a receptor blocker. But if the calcium channel blocker nor the ACE inhibitor on its own, and this you're talking about monotherapy, all right, then the obvious choice will be indapamide. But you must remember that monotherapy is only effective in 12% of patients. The majority of patients require dual or triple therapy. And therefore, although we don't have newer agents, what is new is awareness of the availability of these combinations that are very effective, not only in terms of efficacy, but tolerability. Okay. In terms of morbidity and mortality, all 3 of these agents that I spoke about as first line are effective, but used in combination, is if I, impart no other information, that is the most important message that I'd like to give you, that the side effect profile is better and efficacy is better with combinations of dual and especially triple therapy if your blood pressure is uncontrolled.
Thank you, Dr. Khan. If anybody else would like to ask a question, post it in the chat section or raise your hand. So you can just unmute yourself and ask your question. Dr. Khan, there are many comments in the chat section stating that they really appreciated your excellent presentation for GP management. So thank you on behalf of all the attendees. Seeing that there's nobody else at the moment, you spoke about diet, you spoke at length about BMI. There's so many different diets that are being advocated: vegan, vegetarian, low carb, Banting, Atkins, intermittent fasting. Are you able to comment on these and share your thoughts?
Just punch in www-diet, DASH. That is, what we call the Mediterranean diet, high in vegetables and fruit and polyunsaturates, nuts. So the DASH diet is favored. In terms of what drinks you can use, there's good evidence to show. We always say eat your fruit and drink your vegetables if you do want to drink anything. Beetroot juice, pomegranate juice, pure cocoa, hibiscus tea, just simple measures are all known in hard scientific studies to lower blood pressure. So when it comes to food, I will say the DASH diet. Looking at overall risk, the number one enemy is added sugar and refined carbohydrate, more so than fats. So if you're looking at, as I said, the DASH diet is very close to a Mediterranean diet, considered the best diet. If you're unfamiliar on how to access that information, the simple message you tell your patients: added sugar and refined carbohydrate is far more leading to disease conditions. Find carbohydrate out, then you tackle the fat. And in terms of, because when you look globally, it is populations in excess of 60% that are most prone to hypertension, diabetes, and cardiovascular morbidity and mortality.
Thank you, Dr. Khan. I see.
So I hope that answers in terms of Banting.
You've covered that well, Dr. Khan. There's a question in the chat section, and it speaks to hypertension post-vaccination. Previously well-controlled hypertension becomes more difficult to control and unstable post-vaccination, meaning COVID vaccination. Your comments on that?
God knows, I don't know really why that should be so. I don't know. I haven't come across anything written on that. Why should that be so? What altered? What's altered? I cannot, have any mechanism or why that should be so.
Hypothetically,
unless of course,
hypothetically, is it possibly related to the effects of COVID itself on hypertension and the vaccine producing a COVID type reaction in the body? Because many people get COVID-like symptoms post-vaccination and quite severe at times. Could it be that? Inflammation of the arteries and endothelial dysfunction? It's postulation.
Well, speculation. I certainly don't know the answer.
Speculation.
I certainly don't know the answer.
Are there any other questions, colleagues? Just more, please comment on the use of ACE inhibitors together with ARB. Dr. Khan?
No, not at all. No, absolutely absolutely no. No, you do not combine ACE inhibitors with ARBs. No, not at all. Why would you consider that, using an ACE and an ARB together?
It's a question in the chat. Maybe that colleague will maybe put a hand up and speak to that. I'm not able to.
Yeah, no, we do not combine the two.
There's a comment here, maybe all patients putting on weight, everyone also down psychologically and anxious, talking about COVID. So they're talking about anxiety and stress during COVID. Frozen again, Dr. Khan.
Yeah, sorry, sorry, I just didn't hear all of it. So what did you ask specifically?
There was a comment when we spoke about hypertension and COVID, and a comment from one of the attendees is that perhaps due to a lower level of activity, people are putting on weight, causing blood pressure to go up, and also psychological stress and anxiety. Clearly contributory factors.
Most certainly, most certainly. And here I go even telling you that, you know, so many of these antidepressants also contribute to high blood pressure. So it really, you have to walk a tightrope, and you've got to be informed at every step, you know, in your choices of therapies for the multiple issues that you have to deal with under current trying circumstances. Yeah, certainly that's, you know, a useful comment.
Thank you, Dr. Khan. Then another question, Dr. Khan, you mentioned perindopril as a 24-hour action. Is it the same if enalapril is used twice daily? Is the effect the same?
Oh, certainly, yes. If you know, I didn't spend too much time on that slide, but I listed every popular drug in clinical use and their duration of action. So, you know, the only reason I did that because so many colleagues ask about this, you know, dosing at night, because it really came to the fore, and this study in 2019 that was really showing that that's the way to go. But as I said, you know, the results of that trial just seemed too dramatic to be true. And as I said, both the investigator and the entire trial data are under investigation. So often, many drugs are used as a once daily dose. No, you've got to look at the half-life. That's important, and use it where you get 24-hour effect. And secondly, when you escalate therapy, you've got to wait for an individual drug to reach a steady state level. And a steady state level for most drugs can take 3 to 4 days up to 3 weeks. Therefore, we don't just incrementally add and add and add, okay? So if your blood pressure is grade 1, you start low with the single agent. Even with grade 2, as I said, step 1 is half the dose, low dose. We start low and go slow. We wait to achieve steady state. And this speaks to the fact that the most important thing in terms of controlling blood pressure is you've got to talk to your patient over and over again and inform them that we're not giving you this magic pill that you're going to swallow it tonight and tomorrow you're going to have perfect blood pressure. Not at all. I said in one of my initial slides that we aim to achieve control over a period. You've got to wait and see tolerability. Relay to your patient that this single drug is going to cure your blood pressure, and their disappointment that they've now taken this blood pressure medication and the blood pressure is still high. So this kind of information, especially under current circumstances, must be effectively communicated and reinforced to the patient at every available opportunity.
Thank you, Dr. Khan. Point well made. And there's a comment from Dr. Nell. I would say it's excellent presentation, and I'm not sure if you can answer this question. Why was perindopril dropped in the state and now we have to use BD and enalapril? Are you able to answer or respond?
I know that. I know that. And, it's, with the state sector, they will go for everything that costs 2 cents a month. It all depends on, the tenders and who comes in cheapest. That's the bottom line. Whichever comes. For a long time, I know we did have perindopril, and it's well tolerated, well studied, and in fact, if you look at mortality, it is the only antihypertensive therapy that has 7 major trials showing mortality, morbidity benefit. Enalapril really has the data in heart failure, but when it comes to a patient who's dependent on state healthcare, it really becomes unfortunate because there are multiple comorbidities. Ask any pharmacist the average basket of drugs that a patient at cardiovascular risk. Remember, it's driven by aging and obesity. And with the aging and obesity, everything that I've listed, the blood pressure, the glucose, the cholesterol, and just diabetes alone, you're going to have to take 2 or 3 agents in addition to the aspirin. So the average patient is taking 6 to 8 to 10 drugs. And especially in the state sector, where we don't have these combination drugs, it really becomes very, very difficult. And I take your point entirely. And, maybe we should all make a concerted effort to tell them, adherence is what controls a risk and mortality, and perhaps we should look to making it easier for the patient.
Thanks, Dr. Khan. Bonakela Kabaka, you can come in. You may come in.
Yeah, hi, Jeff. Good evening, Dr. Khan. I just wanted to find out if it's possible to get the presentation slides. I had difficulty quite a few times in hearing her, and also the fact that she was getting cut off, and when she comes back, she has already moved, with some slides. So, yeah, so I was just thinking if it's possible to get them.
Thank you, Bonakela. Dr. Khan?
Not a problem.
Okay.
That's perfectly in order, And I apologize for, the break in transmission. I hope it wasn't too bad.
It wasn't too bad, Dr. Khan. It wasn't too bad, but it just shows that he really values every word that you uttered, and so we'll appreciate the slides. I was going to ask you, someone posted that, and then Dr. Bray mentioned, this is his statement, I would restrict salt intake as a dietary recommendation. Your comment, Dr. Khan?
Most certainly, I concur. Most certainly. That is, a given. I should have, when you asked about diet, I omitted to say that clearly salt restriction, and we favor, potassium salts and, other than sodium chloride. Well, most certainly for hypertension.
Thank you, Dr. Khan. Then in terms of exercise, is there any specific type of exercise is more suitable to helping blood pressure?
When we look at exercise, we look at, there's 2 factors we consider. One is cardiovascular, and the other is resistance training. For cardiovascular benefit, we look at endurance training, that is anything that increases your heart rate. So what we recommend for endurance, is standard 5 times a week for 30 minutes, increase your heart rate. And another 15 minutes a day for resistance training. Now, the reason for that is after the age of 40, we all lose muscle bulk. And we need to maintain muscle bulk not only for mobility, but the major utilizer of food and glucose is muscle. So after the age of 40, as you lose muscle bulk, as you become less mobile, the more you eat, the more there is storage as brown fat in the abdominal cavity. So resistance exercise maintains muscle mass and increases the uptake via insulin receptors in the major muscle groups of your body. So come to exercise. So I said 30 minutes of endurance training, anything that increases your heart rate, and 15 minutes, if you can, of resistance training. And resistance training is you don't have to, push 50 to 100 kilograms. It's just lightweight. It's anything from 1 to 5 kilograms to maintain muscle bulk and muscle tone. I hope that makes sense.
Thank you. That does make sense. Then Dr.
Is that clear?
Yes, it's clear. Thank you. Dr. A. Govender, comment is patients with labile hypertension, many times the normal level, and then very high, for example, 180 over 100, and symptomatic with dizziness. Would you commence with a single agent or a double agent or more?
This is an absolute nightmare, especially in the advanced elderly and especially in females. I don't need to tell you that one of the commonest reasons for admission in elderly patients is orthostatic hypotension and falls. And we see this especially in, as I said, older women. What I use standard fashion is a 24-hour blood pressure monitor. Okay, it gives us a more fair idea as to the level of control so that we are not too aggressive. We aim for a level around 140/90, and in fact, some patients you have to settle for higher blood pressures because the incidence of postural hypotension, this is what the term, this lability that leads to falls. And in elderly patients, fracture neck or femur, is common due to orthostatic hypotension. So in these patients, really, you got to be careful and go for less aggressive lowering of blood pressure. It's a very difficult problem to treat.
Thank you. And then from Dr. Khan, is there still a place for the use of reserpine in the control of difficult hypertensive?
Oh God, not since Noah's Ark. That nobody mentions that. If your blood pressure is difficult to control, as I said, we have those three that I spoke about, the ideal, all right? An ACE inhibitor, a calcium channel blocker, and indapamide. Number 4 is always spironolactone. Okay, you cannot call a patient having resistant hypertension if you don't have spironolactone on board. Then once you have spironolactone, what I would go for, depending on the profile, either beta blocker or an alpha blocker. Now, what I find, the common scenario where you get this is somebody with a severe chronic kidney disease. What works exceptionally well is Casen XL, doxazosin. 4 milligrams, you up-titrate to 8 milligrams. I find that extremely effective. And now that is drug number 5. Then if that still doesn't work, I will add a beta blocker, such as carvedilol, going to maximum doses of 25 BD. With that combination, really show me somebody who still has uncontrolled blood pressure. I will be extremely surprised. So, okay, so your ACE, your calcium channel blocker, your indapamide, followed by spironolactone, then doxazosin, which is, as I said, Casen XL or Cadura XL, 4 milligrams and 8 milligrams, then a beta blocker like carvedilol up to 25 BD. Seriously, I don't see patients who are on all these drugs whose blood pressure is still not controlled. If it's still not controlled, I'm going to look for a secondary cause. And even in an older patient, you may just get atherosclerotic renal artery stenosis, or maybe just, you have such severe atherosclerosis in the aorta or at the origins of the renal arteries that exacerbate hypertension, or you look at concomitant therapies that I had listed that can push up your blood pressure. Or The other thing is in the summer months, drinking too much fluid and having too much salt. It's not uncommon in practice, this fascination with overhydration. You speak to some patients, they tell you they drink 4 liters of water in a 24-hour period, highly recommended by their exercise therapist. That to me is abnormal. So simple things like that. Or, you know, a South African favorite pastime, eating biltong. You know, you really push up your salt intake, or salted nuts. So look at all those things. And if you've excluded that, drugs, lifestyle choices, then perhaps, you know, investigate as to why this blood pressure is uncontrolled, because that's abnormal.
Thank you, Dr. Khan. Dr. Khan, at which point should a GP refer a hypertensive patient to a specialist? What would be the red flags?
As I say, if you have access, if it's pure hypertension, and you know, you have access to a drug like triflixin, which is Servier's drug, triple therapy, effective therapy, you start, you know, and it comes in multiple combinations. You know, as I said, for each drug, it starts from 5 to 10, and there are like 4 combinations. So you can do all of that on your own, okay? Now, for a primary care physician, if you have an ECG machine, just to do a 12-lead ECG, if you can have a urine dipsticks or just send off a urine albumin creatinine ratio. And importantly for me, I always do a HbA1c in a patient. And anybody who has a HbA1c above 5.7%, which is putting a patient in the pre-diabetic or diabetic range, as well as increased abdominal circumference, I will do a GTT, okay? So to answer your question, if you have an ECG machine, very nice to do a 12-lead ECG, very nice to check for proteinuria. But the additional tests that I do, standard dictated by the patient's profile, abdominal obese or just, you know, BMI, that's high. I do a HbA1c followed by GTT if the HbA1c is in the pre-diabetic or diabetic range, a lipogram, and make a decision. Because if you have all of those risk factors, and depending on the age of the patient as well, because remember, advancing age increases your risk. The longer you live, the more likely you are to have a cardiovascular event. Then I will consider. And the reason why, what more can a specialist add? Okay, we've discussed our therapeutic targets, okay? We spoke about primary prevention. We've spoken about secondary prevention. And if you're diabetic, if you have hyperlipidemia, the therapeutic targets are very clear, as in a blood pressure less than 130/80. We look at a LDL, and this is new guidelines, of less than 1.4, okay? And HbA1c as close to 7% as possible. And if you're not achieving those targets, then I will certainly refer to a specialist, and hopefully the specialist can control or have access to more drugs. And what I find very effective, we don't just rush into invasive imaging of arteries, but what's coming more and more to the fore is non-invasive imaging with CT angiography. And I'll speak to this for various reasons. The exercise stress test has a very low sensitivity in detecting coronary artery disease. It is in the region of 40%. What we are using more and more is non-invasive imaging with CT scan, not only to exclude obstructive lesions, but it gives you an excellent idea that even if lesions are non-obstructive, the extent of atherosclerosis in a coronary artery. And that is a huge driver of aggressive therapy. So what I'm actually saying, if you do a CT scan, okay, in a patient with a high risk profile, it actually forces your hand as well as indicates to the patient, you may not have an obstructive lesion, but you may have extensive atherosclerosis. They do that, number one, by just imaging the arteries and looking for atherosclerosis, or just purely looking at the calcium score that gives you an indication of vascular aging. And that then not only is a motivation for you, for the patient, but also to the funder, because the whole idea of everything we do is only one: to minimize the risk of a future cardiovascular event, which is the commonest cause of death worldwide. I hope that makes sense.
Thank you, Dr. Khan. It does. And then albumin-creatinine ratio. We routinely do this on hypertensive and diabetics. Could you give us some guidelines in terms of interpretation and action that GP should take when the levels are elevated?
Action is very clear: sticking to your therapeutic targets. Okay, we've spoke to that. All right, primary and secondary prevention. The guidelines are very clear on that. So all of these things are just additive in terms of forcing your hand to be more aggressive. But the bottom line is know your therapeutic targets like how you know nursery rhymes, and do everything in your power to adhere to that.
Thank you.
And I hope I made the therapeutic targets clear by reinforcing over and over again.
We really appreciated that. Then the last line in your bio, there are several ongoing studies on molecular mechanisms of atherosclerosis, novel signaling pathway sirtuins and microRNAs. Can we pick your brain before you go and ask you to share your thoughts on that?
Sorry, there are a lot of it that I didn't see here. It got.
I'll say it again.
Can you hear me?
I can hear you. Are you able to hear me?
Yes, you know, we're always chasing a quick answer, all right? There's so much that's written on microRNAs, the mitochondria, but to date, no magic. The bottom line is we plan for 100-year lifespan. The two commonest causes of death: number one, cardiovascular; number two, cancer. Research has shown over and over again that both these share a common soil. What drives cancer risk is almost identical to what drives cardiovascular risk. Just that the longer you live, the more likely you are to die a cardiovascular death. A cancer mortality plateaus by the time you reach your mid to late 70s. But every day you live longer. And as I say, we plan for a 100-year lifespan. Remember, the data is quite hard. If you're in your 50s and below, more than 50% of those in their 50s today will reach or live to be over 100. We're not saying we're going to do away with death, yet the biggest investment that Apple and Google have made is to see aging as a disease process in itself, okay? That's the biggest investment. It's not in newer technologies, but it is directly, specifically towards viewing aging itself as a disease process. So the longer you live, atherosclerotic cardiovascular diseases, higher incidence. Cancer tends to plateau. They have a common soil. The holy grail is obviously, to find what it is that will attenuate the aging process. What we do know, and therefore there's so much negative publicity about statins, but what we do know, you can determine how long you live by measuring the length of your DNA. All of us are born DNA, half from mother, half from father. We are born with a given length of DNA. Every time a cell replicates, our DNA shortens. So you can actually work out exactly when you're going to die by the length of your DNA, by measuring the terminal portion called a telomere. And the only thing ever shown to prolong or preserve the length of the telomere is a statin. So statins not only in cardiovascular disease, but also there is good basic science evidence to show that it also attenuates certain cancers. So when you look at primary prevention and you look at all the data, there's two things we look at. You don't have high blood pressure, you don't have diabetes, you don't have much, but to attenuate cardiovascular morbidity, mortality, higher-pay statins, and I don't know why there's so much negative publicity against statins. Statins are important.
Thank you, Dr. Khan. It's almost 9 o'clock. Thanks very much. We really appreciate it as GPs, receiving this value-adding and fascinating talk by someone of your stature, experience, and knowledge. And thank you for freely sharing of your knowledge and also allowing us to receive your presentation. We also would like to thank Servier for connecting us with you and partnering to make this possible. We hope that we'll be able to engage with you again in the future. Thanks very much. We wish you well and trust that you will stay safe. I'm asking Bronwyn to unmute. Bronwyn, and I'll give you the opportunity to say a few words before we close. Thank you very much, Dr. Khan.
Good evening, everyone. Thank you for that amazing, enlightening talk. I've learned a lot. And I think the interaction from everyone that's online was incredible. And I think we all can take quite a few key messages home there in the management of hypertension. It's something I do believe that's still a very relevant day-to-day challenge in all of our lives, whether it's personal or in the professional that we all are in. And I really do believe we can go to bed tonight with a lot of information to digest. And wow, Dr. Khan, thank you so much for your insights. And then most especially to Dr. Jeff Govender for giving us Servier, the sponsors, the opportunity to present tonight and have Dr. Khan as the host. We really do appreciate it. Thank you so much for facilitating that, Dr. Jeff.
Thank you, Bronwyn, for all your efforts in facilitating and being present with your colleagues at this talk. We wish everyone good night and stay safe. And thanks to all our colleagues for your contributions to healthcare in South Africa, especially during the COVID pandemic. Bye, everybody.
Be safe.